got into this field because it was clear to me that one of the ways to strengthen public health and the public health infrastructure overall was really through the focus and public attention on preparedness. That in some important way it can serve as the point of the spear for many of the things that we need to do in public health. And frankly, vice versa, that strong public health and strong public health systems will make us better prepared and better able to deal with adversity. So since I've been in this job, I've had the, I don't know, pleasure, honor, challenge, whatever you want to call it, of dealing now with 4 very complex, very different kinds of events. The H1N1 pandemic, our response to the Haiti earthquake and its aftermath, the Gulf oil spill, and now most recently the situation, particularly the nuclear situation in Japan. It's interesting because each one of these calls on core components of our public health infrastructure, really in very different ways, shows us why they need to be strong, and shows us why, if we're going to have a prepared country, we need to invest in the basic public health infrastructure of our country. And in saying that, I don't mean that we should build it back to the way it has been, because I think it's pretty antiquated and pretty inefficient and often pretty wasteful, but that there are core functions and core capabilities that we need to have in place, and they need to be strong and they need to be working. So I just put a couple of examples under each of these events on this slide just so that you had a sense of what I was talking about. And I think, you know, most of you are pretty familiar with many of the challenges that we all faced through the H1N1 pandemic. But first to say, you know, if you have a rickety surveillance system, if you have surveillance systems that aren't strong, you're going to detect disease late. In fact, I think we all understand now that had we detected this disease when it first showed up in the world, 3 or 4 weeks before we actually recognized it, we would have had vaccine 3 or 4 weeks early. And we would have been able to vaccinate a lot more people and probably be ahead of the peak of disease. Same with epidemiologic investigation and capacity. Same with lab capacity. Really core functions of public health that are critically important day to day. At the other end of the spectrum, and I really have this talking about Japan, but it really relates to all of these issues. You know, if you can't communicate with your public, help them understand what's going on, help them understand what they can do to protect themselves. You know, whether it's wash your hands, cover your cough, stay home when sick, or whether it's stay inside when a radiation plume is passing overhead. You can't tell people what to do, you can't help them protect themselves. And the communication aspects of what we do in public health, I don't think can ever be underestimated. The earthquake in Haiti challenged us in very different ways. For my office, it was our first ever large-scale international deployment, and it happened at a time when we didn't have a whole-of-government plan for how we were going to respond to a complex emergency in another country. And it certainly showed us that planning is everything, and it certainly showed us the complexity of many of the things that we dealt with. Our National Disaster Medical System teams at the end of the day took care of over 30,000 patients, did pretty amazing things, saved a lot of lives, dealt with a lot of the consequences of a country and a set of communities that, as you know, had long been in chaos and in poverty. When we talk about resilient infrastructure, we also have to deal with things like zoning codes, and that you don't, you know, build buildings that can fall apart when the wind blows or when the earth shakes. And that is part of resilience that we don't talk very much about in public health, for example. But, you know, one of the things that really challenged us in the Haiti earthquake for us, and for me and my office in particular, was sort of this issue that we don't like to talk very much about in public health at all, which is how do we think about allocating scarce resources? We obviously couldn't take care of everybody there. There was a huge demand on the part of many, including folks in DOD who are operating on people on the comfort and on the part of many NGOs to provide an American standard of care to people living in Haiti. And when they operated on people and found that there was no place to send them post-op where they could get an American standard of care, they wanted to fly them all back to the United States. And in fact, early on, they started doing that. And then somebody realized, well, somebody has to pay for their care when they come to the United States. And then we needed to think about, well, who should come back to the United States for care? How do we make that decision? What are the principles for doing that? You know, fortunately, in the run-up to H1N1, we'd asked the Institute of Medicine to think about a framework for how we get to and use crisis standards of care in an emergency. And thankfully, we didn't really have to use that in H1N1. But we used that framework and its guidance tremendously during the Haiti earthquake. It's really important. But it's a challenge that I think we all face as practitioners of public health all the time. The Gulf oil spill was a different beast altogether. I think it took a long time for many to understand that there might be public health and public health consequences. And this was, you know, by and large, a massive environmental disaster, as I think we all understand. And I think we all understand the links between environment and health. And again, the complexity of that interaction. In fact, that was my early experience with lead. But this was an emergency where almost all of the morbidity was behavioral health. And we came to terms with the fact that it was difficult to recognize, it was difficult to measure, and about the only thing that we really knew from the 35 oil spills that preceded Deepwater was the fact that any one of them that had been studied had been associated with significant mental health morbidity. In some, upwards of 40% of the population experience significant, not only short-term but long-term psychological morbidity. Yet we had no idea how to prevent it. So I kept thinking about, how do we shift this curve to the left? How do we prevent this? And we didn't have the knowledge to do it. We didn't really have the systems to do it. Fledgling, or better, maybe systems in place, particularly around New Orleans and other areas where lots of people had been trained to do lay crisis counseling. Probably a great model for how you build resilience. And many of those people went out and worked with fishermen and others whose livelihoods were really affected. We don't know if that works. It feels good. Don't know if it works. Don't know if it's the best way to accomplish this. There's just not a huge amount of evidence in this area. Another important place to work. But we know that if we want to have a prepared and resilient nation, we're going to have to pay some significant attention to behavioral health. And finally, obviously, now the situation that we are dealing with in Japan, very fortunately, hasn't had large health and public health consequences for the U.S. There have been some things that I would call annoyances that have caused people to spin around in lots of circles. You know, radiation detectors go off in the airports when people come through. Customs and Border Patrol is not so sure what to do. The poor people who set off the radiation detectors are scared as all get out because they're radioactive in one way or another. And the public doesn't have a really good understanding of radiation or radioactivity. But by the same token, when the public hears that there's radiation in their rainwater or their drinking water or in their milk, they get really scared. And so we've had more than anything else, sort of a, not terribly serious, but a mild epidemic anyway of fear. In some communities, probably more than mild. I'm looking at Susan, who's in Washington State, where some of the first reports of radiation in water and milk came, and I think people were pretty wigged out by it, to say the least. And so again, it teaches us about what the needs are in terms of communication and how central those things are, and how a series of kind of unanticipated events, really a great example of failure of imagination here. An earthquake followed by a tsunami, followed by nuclear power plant destruction, leads to consequences for the whole world. So those are, just a couple of examples of how some of the things that we take for granted we do in public health day in and day out have to be really, really strong if we're going to be able to be a prepared country that can respond to public health emergencies. I go around a lot saying, if you can't do it every day, you can't do it on game day. I firmly believe that the things that we do day in, day out in the practice of public health are the things we have to do in an emergency. And if we can't do them very well day in and day out, we're not going to be able to do them to scale. And so much of the focus of and energy that I've been putting into this has been really to think about what are those things that we need to strengthen day in and day out. So you already heard me talk about if you've got a rickety surveillance system, you're not going to be able to detect disease. If you've got a rickety system for distributing antivirals or vaccines to a population, it's going to be pretty slow and rickety. If you can't communicate with people about the safety of vaccine, or if you're ineffective at doing it, the public's not going to accept and use the countermeasures that are available. And in a situation that's much more serious than H1N1, you certainly don't want 50% of the population deciding that they shouldn't take a countermeasure, because that can obviously be dangerous and deadly.